Good morning, everyone. I'm just going to go ahead and kick off if that's okay with everyone. Tom, I'll pass it to you in a moment. Just wanted to orient everyone. We want to do this during every meeting moving forward of just who we are, what A.D.A.P.T is on a high level. We're a group that is a non-member group. We do drills, we do training, we meet in person and in Zoom. We're mainly comprised of Atherton residents and focused on disaster preparedness, arming you, your neighbor, your family, and everyone to make sure we're on the same page with town-wide processes, but also what to do in your own household, what to do in different scenarios, what to do when you need a mini fire extinguisher under your bed. We have all the answers, and we want to be able to share them with you. Atherton is divided into 14 areas. Each one has an area coordinator in a perfect world. Right now, we're missing a few area coordinators in certain areas. I think area 4 is one of them. We are going to be meeting in person at National Night Out. We'll have a giant map there. You guys can see where you're located, what area you're in. If you can't wait that long, we hope you won't wait that long. Please go to our website and look up where your area is and who your area coordinator is. Get a map of your area, find out where the little sign is called an A.D.A.P.T, where you'd meet during a disaster, and all of that. Our website is being revamped on the daily, and we're here to help. So again, we are partnered with the Atherton Police Department. We're not some random rogue group. The town supports us in many different ways, and we, on a high level, meet once a month on the first Saturday of each month for a community meeting. Lately, in 2021, we've been doing advanced trainings, which have been 2 times a month for our area coordinators that I mentioned previously. So there's different levels of training. Tom Pressing knows a lot about disaster preparedness, and I'm not even giving him full credit. There's just so much, the wealth of knowledge that this organization has stemming from Tom. So we are getting trained on all of that. Really quick, that's him in the upper left. We have some board members here. We also have a bunch of dedicated volunteers, like I just said, area coordinators, block coordinators. So this group you see on the screen is not anyone who's running the show. We just wanted to highlight who we are in case you wanted to communicate with us. We've got Rebecca, Tom Owen, John Mosby, myself, and Jerry. And that's our board at the moment. And we welcome you to our June 1st community meeting. Tom, I think you can go ahead. I think, unless Rebecca, I'm missing something. Oh, I was going to do the poll.
Yes, poll. Yeah, let's do the poll.
Okay, when it comes to thanks guys for letting me be a little informal here. We are trying to figure out ways to meet in person, but also before we figure out ways, we need to better understand where you guys are at in terms of comfortability of meeting in person. We'd love to do a recognition event of some sort, something informal, a get together, or even just figure out if we should meet together in person in community meetings. So this poll I'm gonna launch is completely anonymous. I might not even show the results. I'll just probably collect them. We'll see, but we wanna gauge your comfortability of meeting in person in the near future. Let's just say, assume it's for sometime in 2021. So I'm gonna launch this poll and have you guys select your answers. If you were to meet in person, would you be very uncomfortable, somewhat uncomfortable? Would you attend, would you not? Pending that your schedules work.
And Jeannie, let's just go ahead and share it so everybody kind of gets a flavor of where the whole group is at.
All right. If anyone else wants to go, we've got 11, 12 people who participated. More. You guys are pretty darn comfortable. All right, I'll end the poll in a minute, maybe 10 or 15 more seconds. A few more coming in. I need 3 more responses if anyone else wants to. All right, I'm gonna end it and then you guys can see, let me see if, I'm gonna take a screenshot just in case. All right, can you guys see the results? Looks like you guys are pretty comfortable or somewhat comfortable, so that's good. We do have a few people. I'm definitely on like the more conservative side, but that's why we're asking this. It seems like we've got 20 people who would at least consider attending it or definitely want to be in person. So that's encouraging, and that's also encouraging for the drill that's coming up because it is in person. So with that, did you guys all see the results okay?
Mm-hmm.
Great. All right. Well, I got them captured here, and thank you for that. Thanks for letting us do a little housekeeping. Today we're going to learn about, summer hazards, fire remediation, but also more first aid and medical. And you'll get a bunch of tips that you can use moving forward during a disaster, but also not during a disaster that you can just use and have in your arsenal. So with that, Tom, go ahead.
Happy Saturday. What a beautiful day. Chief Steve McCulley, thank you for joining us. Real quickly before we get started with the Chief's report and then my presentation on wildfire preparation. On August 3rd, we have National Night Out, and A.D.A.P.T has always participated in that. We have a booth with a canopy. We are out supporting the police department and the incredible job they do in keeping our community safe. And that's what National Night Out is recognition our our sheriff and our police departments, as I said, who keep us safe. We will be setting up around 5 o'clock. The event goes from approximately from 6 to 8. So we hopefully will have a sign up on the website that if you want to join us, we would love to have you help us set up and then help us man the booth and walk around and talk to folks and encourage them to join A.D.A.P.T. On September 11th, we are going to have our in-person drill. We haven't had a drill since our September drill in 2019. That'll be sponsored by the town, the police department, and the Menlo Park Fire Protection District. And it should be an amazing event. Last time we did it, we had 131 folks with enormous numbers of events and activities. Matter of fact, Jeannie was the incident commander, and we did a tremendous job. Felton Gables will be the neighborhood that is involved along with Holbrook Palmer Park. That information is also on the website. In October, and we're finalizing the date, so October is definitely the time, the town of Atherton with the police department has generously paid for 24 slots in this advanced first aid class that we're going to present to the community. It'll be based on, first area code 94027, and then those adapters who are outside of 94027, if there are slots left over, then you will certainly be given the opportunity to join this free advanced first aid class put on by a company called the First 5 Minutes, which has a tremendous reputation. Their instructors are EMTs, Army medics, doctors. The head of the organization is an ER doctor. We will be letting you know about that. So the 3 events coming up: National Night Out on the 3rd, September 11th, our community emergency drill number 5, and then last but not least, the advanced first aid class for adapters in October. So thank you very much. Look to the website to get involved in that. Chief McCulley, are you there this morning?
I am here live from H.D. Park. Good morning, everybody. It's great to see everybody. And so, and we have we have 30 people now. That's outstanding. It's a great discussion about meeting in person. I know the town is having those same discussions, and I believe council is recommending, which I think is a great idea, not only hosting in-person meetings, but also Zoom. I think we've seen a lot more increase in activity and participation in our council meetings and with our A.D.A.P.T meetings. Real quick, just so I don't waste your time, we've had many more additions to the police department. We lost a couple sergeants. We now have 2 sergeants that I've just sworn in the last couple of weeks. So we'll be working quickly to identify our new sergeant, who will be the A.D.A.P.T representative to carry the torch for us. Commander and I will still be involved. I continue to work with Tom on the disaster service worker designation. Sometimes these things take a little longer than we thought, but we are working on that in our volunteer program. Tom mentioned National Night Out. We are really excited about having National Night Out in person again this year. We're going to pull out all the stops, make it bigger and better. Called the Highway Patrol to reserve the helicopter. So we are looking for all adapters to come out and enjoy the great food and all the activities that we are going to have. Looking forward to the drill in September. We will involve as many of the officers as we can to get them involved in the A.D.A.P.T program. And then lastly, like Tom mentioned, the first aid program, we're excited about offering that to our residents. This isn't a one and done. We'll be continuing to do first aid classes if there is demand. We are able to offer that free, which is outstanding. And it's a great course. It does take 3 sessions. It's a lot of time, but I think you'll find it well worth your time. So with that, Tom, I'm going to hand it back over to you. I may have to leave in a little bit, but everybody have a great meeting and looking forward to seeing everybody in an in-person meeting soon.
Thank you, Chief. Thank you very much. One additional thing, our advanced leadership training for area coordinators is always on the 2nd Tuesday of the month and the 4th Thursday of every month. So if you're interested in that, please check the website and
actually email me or put your email in the chat if you're interested, because it's for
okay.
We don't have it publicized.
Okay. Oh, gotcha. Okay, very good. If you want to join it, as Jeannie said, put your email in the chat. This morning we have 2 topics. Our first topic is a wildfire preparedness review, followed by a outstanding presentation by Dr. Barbara Kostic, who is one of the co-leaders of our A.D.A.P.T medical team, and she's going to cover what to do with the 5 most common injuries in an earthquake, which turns out to be one of the 5 most common injuries in your own household on a daily basis. And this is all in preparation for daily life, an earthquake should it happen, and even more importantly, for your participation in the community emergency drill. So the next 2 Saturdays, we're going to talk about first aid and first aid operations, so that when we do our drill, those of you who are out in the field doing triage and transport and helping injured folks, you'll have a good foundation for that. A little review as far as wildland preparedness and wildfire preparedness is, in Northern California, our rainfall is 46% of normal. In Central California, it's 52% of normal. And in Southern California, 34%. This is as of last Wednesday, according to the state of California. That means overall in the state of California, our rainfall is at 44%. Consequently, our reservoirs are very, very low. If you've seen the recent pictures of Orville Dam, you would be quite amazed that it's nearly empty. Our snowpack is at 59% of normal. Bear Gulch, which is is up above Atherton, its normal depth is 576 feet. Right now, as of June 4th, which was yesterday, it's at 541 feet. So the nice thing about the Bear Gulch Reservoir, which services Atherton and the 55,000 other people that are part of that water distribution system. So we're part of the 55,000. We make up 13% of the area that is covered by that Bear Gulch, but it's 93% full. So we're really, really, really lucky there. And Bear Gulch would become a resource for helicopter fire suppression. So the helicopters would come in with the big buckets and could be used for that. So that's just a little bit of a background, knowing what the drought conditions are and how they affect us. If you look at an aerial map of Atherton, you'll see that to the north, Redwood City is gray-green, more gray than green. To the south in Menlo Park, it's green-gray, a little, about half green and half gray. You look at Atherton, it's all green. In other words, we're blessed with a huge amount of, foliage and woodlands coverage, which is really great for the bucolic atmosphere that Atherton has, but it also lends itself to the potential of canopy fire, and we have to be aware of it. In terms of making sure you have done the best you can for this upcoming fire season, which has already been portended by all the experts to be another tough one, is keep your property clear of overgrowth. So, start now with your gardeners and start cutting back as much as you can, cleaning up the fuel that's on the ground, because fire needs fuel, heat, and oxygen. Heat, hot weather, and oxygen, we have plenty of it. And then, so you want your primary goal is to eliminate the fuel. Make sure you clear off your roofs of potential fire fuel. So that's the pine needles and the leaves from the various trees and any other debris. And, as graciously as you know how, remind your neighbors to do so as well, because it's a mutual safety issue. Store your flammables in a safe manner as you can. Those of you who have, let's say, gasoline for your generators, then I would recommend that you store them in metal jerry cans in a way that is separate from the house. Your propane tanks should be stored separate from the house and try to keep them out of the heat. And so store them as best you can. With regards to flammables, though a lot of folks use plastic, it is better to use metal because it's more secure. Strategically place fire extinguishers on your property for quick fire response. So on the property I literally have fire extinguishers in 3 locations in the backyard. Because it's an L-shaped backyard, I have one in the middle near the orange tree, and then I have 2 at each of the far ends of the garden so that I can do quick response. Know the capability of your water resource for fire suppression. Those of you who have sprinklers on your roof, or you have a pool pump that gives you firefighting capability from your swimming pool, practice it. Just get, start up the pump, get the hoses into the swimming pool, connect your hoses first, start up your pump, and practice laying down water in a perimeter fashion so that when you have to do it quickly, you are comfortable doing so. Make sure you have a provisioned bug out bag. We've talked about this before. My bug out bag is always in the car, but you may have it at the front door or wherever you wish to have it. Have a practiced evacuation plan in advance with alternative routes and destinations. And even the destination should have an alternate. Time your primary evacuation routes so that you have full understanding of your escape options. So make a day of it if you have a family. Say, okay, drill time, and everybody grabs their bug out bag, they get in their car, you follow your map that you have pre-created for your evacuation route to a destination. Time it so you know how long it takes, because there's probably going to be you and other people evacuating, but at least you know what the minimum time is so that you can also know about traffic, stop lights, stop signs, and whatever. And then, go out to lunch or go to Baskin Robbins and have an ice cream. Those of you who, I do recommend that if you are comfortable doing so, have a chainsaw in your as part of your bug out process, because if you have to evacuate either in an earthquake or in a fire, there may be debris on the road, and you may have to use the chainsaw to clear it. Those of you who have chainsaws, practice using them safely so that when a time comes, you're not rushed and are not unfamiliar. If you do not know how to use a chainsaw, interestingly enough, a lot of the rental places around here will actually give you some training on how to use a chainsaw safely. And we are looking at doing a Zoom presentation out in a open area where we would get a demonstration on how to use chainsaws effectively. Have a practice pet evacuation plan, especially for those of you who live west of Alameda de los Pogos who have larger pets or animals. For those of you who do have larger pets and animals like llamas and goats or livestock like chickens, time your primary evacuation route so that you have full understanding of the escape options capable, which means that at the start of the drill, you know, how long does it take to load up your chickens, llamas, and goats or large pets into your carriers? Maybe you have horses, you know, and that's really important, that timing factor, getting those animals into your vehicle drawn carriers, your trailers, and then time yourself out. Again, be aware that your evacuation route may not be clear, so you have to be able to clear it. Be aware of smoke conditions as they pertain to your overall response and health capability. So a while back, we got for A.D.A.P.T. You probably can't see it because the PowerPoint is up. We had what's called a fire escape kit by the Go Time folks. And we were able to get a tremendous discount because we're part of the police department. So a whole bunch of us have that. So Dory has one on her side of the bed. I have one on my side of the bed. Turns out Jeannie does too. She just shared with us that she has it. Now, in addition to that, and we'll have that information on the website, I've augmented it with a bottle of water. These really, really neat. It's by Cold Fire. Hand fire extinguishers to be able to clear a path in front of you in case you need to. And then last but not least, because of smoke inhalation, what we've always been recommending is boost oxygen, which will keep your lungs clear. Now, the fire escape kit has a fire hood on it that will give you fire protection and breathable air for up to 30 minutes. So those of you who are interested in that, put your interest in the chat. And if we get enough, then I'll order, the last time we ordered 50 of these and got a tremendous discount, and they went quite quickly. We'll order another bunch. I'm in communication with the owner of the company. Let's see. So boost oxygen, by the way, really, really critical to be in your kits, so that if there's lots of smoke, that you're going to be able to keep your lungs clear. Be aware of wind and weather conditions. Just remember, generally speaking, the wind blows towards the bay in the morning and off the bay in the afternoon. Knowing that is important as you take a look at fire threat as it pertains, let's say, to a canopy fire. Be aware of other situations that can create a canopy fire, like a gas explosion, the unlikelihood of an airplane crash from surf air, or a train derailment. Those are pretty, low profile events. But be aware of the other situations. Let's say a car crashes into an electrical pole, the electrical pole falls and sparks a fire. Just be aware of those things so that you're not blindsided. And then last but not least, stay tuned into SMC Alert and Zone Haven. When Zone Haven comes on board, sign up for both. So that's my real brief overview. This outline that I just shared with you will be on the website. so that you can then print it off, especially area coordinators, you can print it off and make it part of both your manuals as well as passing it out to your neighbors. This is kind of a neat little checklist that if you would go through the checklist, I really think that you'll be best prepared for the upcoming fire season. Any questions?
Thank you, Tom. That's great. And I just put up some resources here that support the things you were talking about: evacuation routes, supplies to have on hand. All of this is on our website. So there's a link there. If you don't already have these resources, that will give more detail to what Tom just discussed. Thank you, Tom.
You're welcome.
Any other questions about wildfire? Or we'll go on. All right, we're very lucky to have Dr. Barbara Kostick here today. I'm going to stop my share because we're going on to a new thing. She is a recently retired medical doctor, was the chief of staff at Washington Hospital here in the Bay Area, was actually voted the best doctor. And now that she's retired, she's gracing us with her presence. She's co-lead of the medical team, as Tom said. She's taught at Stanford and UCSF, and she has prepared for us today a special presentation that talks specifically about medical skills you need to know in a large-scale disaster. So the past couple meetings, we talked about what happens if there's a disaster. You take care of yourself, you take care of your family. And today we're going to talk about what happens if you encounter medical injuries along the way, how to find out what they might be, and then how to take care of them. So without further ado, I will pass it over to you, Barbara, and I'm going to start my screen share with your presentation. And just let me know when you want to go to the next slide and I will pop it along.
Okay. Yeah, so this is basic first aid in a large scale disaster. Rebecca, this is what Tom wanted to talk about, and he gave me an outline of the things that he thought were important for us to know. So that's what we're going to talk about today. We're also going to talk about not just how to take care of them, because first aid on a lot of them are very straightforward and limited, but I want you to know the background of it. And I want you to know what's important to you so that you can help out in a major disaster. So I've sort of pointed the discussion in that area. Next screen, please. So grab your bag and let's go to the EAP. Now, what we need to know is what to do with the victim. This is important that we have to introduce ourselves by name. We have to ask them their name, try to get a history of the injury. We're going to perform triage, and we'll talk more about that. We'll treat some medical issues and know which ones we have to get taken care of quickly. And then, as Tom says, we need to sustain a very calm manner in the midst of this chaos. Because although all of us are going to have a little bit elevated heart rate, we would like to calm the person we're taking care of. Next. So let's see how good you are on knowing these things. Can you name one of the top 5 most common emergencies in a large-scale disaster? And if you think that's a little too easy, go ahead and name all 5. So we have a quiz. Are you going to answer in chat? Is that it, Rebecca?
Sure, we can put the answers in the chat. If you click on the, looks like a little bubble that says chat at the bottom of your Zoom screen, and type in to everyone what you think are the most common emergencies or injuries in a large scale disaster, things that can happen to your family or your neighbors that need medical attention.
And we could just go to the next slide and give you a few hints.
Okay.
Let's see, someone answered. Yes, very good, Jeannie. I don't see much participation, guys. Come on.
We're looking for injuries. Oh,
Top
injuries.
5 most common injuries. What are we going to treat as first responders?
I see fire. I see crush and an earthquake. Those are both good. Are those in the top 5? Dr.
One
Kostick?
is. What do you think the person is worried about that just fell down? Shock is very good. Yes, the fall and broken bones, right? You got 3. stress, definitely, and even after the injury. And let's go and find out what the other ones were. There's burns, we got that one. The fractures we got. Bleeding, big cause. Head trauma and shock. So I think we got 3 of the 5, but I think you probably didn't think about bleeding and head trauma because those are kind of wrapped into some of the other things that happen. Although the leading cause of death in major ones is head trauma and shock. And we'll talk later at the end of that. So let's go to burns. Next slide. Quiz 2. Oh, we don't even get to go to burns yet. I need to put up my outline. Let's talk about triage. Now this is even going to be harder, guys, but there's no wrong answers. So can you tell us what you think triage means? Type slowly, type quickly.
Make sure you are typing to everyone and not direct messaging me or someone else. I'm getting some of those.
Take care of them. How to, yes, triage, take care of them to find out. So good, very good. Excellent, I don't have to even talk. Okay, let's keep going. Next step. Triage. So there's a triage scoring system called START. This is the one that was developed by field volunteers, and it's one of the simplest ones that has good sensitivity and specificity. And so it measures the ambulation, the respiration, perfusion, and mental status of each victim. And it can only take like 45 minutes to 2 minutes, to 45 seconds to 2 minutes to do. This is what we need to learn how to do. So let's see how to do it. Next slide, please. Can I just go? So here is how you do the assessment. We have little laminated cards that most of us responders carry around that have this information in it. What you want to do is you want to determine on if the patient is immediate care, if he can have delayed care, or if he's minor, walking wounded, ambulatory with good mental status, then he might even be able to help with us and taking care of the rest of the victims. So immediate care, any of you know what capillary refill means? Anybody want to know what it means? You all know, you just press the little finger like this till it blanches, and then you look to see if it takes 1 to 2 seconds to get pink again. So do that all with yourselves now and make sure that you can do that. How do you measure heart rate? Well, you got to find out, you're not going to have a stethoscope, so you're going to have to find one of your peripheral pulses. So where are those? Let's see, we've got, the one I like to use is in my neck. It's right here because it's easy to do. You have one on your temple. You have one on your wrist, on the radial side, that's your thumb side of the wrist, the radial artery. And then you have some that are a little harder to feel, like the brachial, and you have some on the lower extremities. You have 2 on your feet you can check. One around what's called the medial malleolus, which is on the inside bone of your ankle. And the other is the posterior tibialis, that's on the lateral side of the ankle towards the back, around that bone. Next. Oh, breathing. I want you guys to try to count your breaths just for the next 15 seconds. Did you find out you can't do it?
It's
yes.
hard.
It's hard, right? You can unmute everybody if you want to. We can all chat it.
Oh God, Barbara, don't say that.
Okay.
Chaos.
I'm used to having feedback. Okay.
And I'll give you a question and a feedback. And when it comes to breathing, do you count an inhale, exhale pair as one breath? Is
Yes,
that the
you
one
do.
count?
Yes.
Okay.
But breathing is part autonomic, not controlled by you, and part controlled by you. That's why you can't count your own. So now what about pulses? You know, when I check a pulse, if I only have 45 seconds to evaluate the patient, I can't feel the heart rate for a minute, right? That's not enough time. But you'll find with that if you check it for 15 seconds, that's enough, and multiply by 4. I find it easier to multiply by 4 than to multiply by 6 and do it just for 10 seconds. And the other thing you want to do when you check the pulse is check for the regularity of the pulse. Is it regular or is it irregular? That's all you have to know. And also you want to check for how strong it is. Is it a weak pulse that you can barely find, or is it a good, strong pulse? Next. So what are we going to do about burns? First topic. Well, first we have to know what a burn is. So, and how deep it is, because treatment depends on how we classify the burn. So it's classified into superficial, partial, full, superficial and thick, or full thickness. Those are the 4 kinds of burns. And if you look, stay back to the anatomy. If you look at the anatomy of the skin, see, here's the superficial. Here's the superficial, partial, and thick, and full thickness all the way down. See this little yellow chicken fat down here? This is what we call the subcutaneous tissue. And when you look in a burn and see that, you already know you're down to deep partial. And when you see muscle, this little area down here, down at the bottom, yeah, thanks, Rebecca, I forgot, I can't use my pointer. Then that is the muscle that you usually see. And then also look at the skin around the burn. Are there hair follicles there? They should be burned away. So look for that. Okay, next. So let's figure out an easy way to tell the difference. So the things that you need to know is a superficial you can get at home. You scald water on yourself and it just turns red, no blisters, that's superficial and it's painful. Superficial partial, you'll get blisters, but it'll be moist and red and it'll be painful. But when you touch around it, you'll see that the circulation comes back to it easily. However, when the deeper tissues are damaged where the blood supply is, then the blanching is slower when you press it. But because pain fibers are near the surface, the sensation is less. So it doesn't hurt as much, even though it's deeper and more serious. So you see, if you understand a little of the anatomy and the nomenclature, you really understand the process, and then you can figure out how to treat it or if you should send it to someone else. Next. So do we treat the minor burn or do we transport it? Well, first, as a caveat, burns develop, the idea of how deep the burn is develops over time. Sometimes you'll think the burn is minor, and then when you check it half an hour later, you'll say, oh, that looks a lot worse than what I thought. Sometimes when you think it's worse and you check it half an hour later and you've done what we talk about, it looks better. So you can upgrade it. However, there are some things that the most burn centers want, and they want any patient who is between 10 and 50 years of age, if they have a partial thickness burn that covers over 10% of their TBSA, total body surface area. If it's a full thickness, it only has to be more than 2%, which isn't very much. I mean, that's like one finger. Also, they like to treat any kinds of hands and feet because those are special areas, and the face, scarring on the face would be bad. And also for function, especially hands and feet, you have to bandage differently. You get compartment syndromes and other problems that you wouldn't get with just a simple burn to the upper extremity or the leg. Then you look at the patient who is under 10 or over 50. And over 50, they have medical problems and other comorbidities like diabetes and heart disease. Under 10, they're still growing. And if they scar, that scar grows, it doesn't shrink. And then it contracts and they get into more problems. So those are also patients that need to be shipped to a hospital or burn center that can take care of them. Now, how are you going to judge if it's less than 10%, 5%? What is that? One of the things we learned back, yeah, thank you. One of the things we learned was in school was the rule of nines, that, you know, if it's all the one extremity, it's 9%. That is a very, very rough estimate. It's not quite correct, especially in younger kids because their trunk is so much bigger than their extremities. But at least it's something you can remember quickly. And it's okay to overestimate a burn. No one will get you in trouble for sending someone and you overestimated it by 5%. They will get mad at you if you underestimate it and you tried to treat it yourself, and then you get into trouble. So err on the side of caution. Next. So treatment of thermal burns, you cool them, you clean them, and dress them. Okay, we're done. So what do we do? What do we use to cool the burn? True or false? Do we use ice chips? Do we use water and ice mixed together in a slurry?
Do you want me to launch the poll
Yeah,
with the true false? Okay.
please.
We've got the questions up here next, but there's 4 true false on here, and then I'll show the results. Can you guys see it now? I hope.
I can see it.
Okay. 0 of you have voted.
It's
So
4 questions.
start making
but
some guesses.
It might
Oh,
take
here we
a
go.
second.
Yeah.
Oh, and be sure to scroll. Yeah, so you see all the questions.
Yeah, there are 4 total. We've got 7 people so far. Keep going, guys.
Yeah.
We've got 12 or 13. Let me know when you want me to end it.
You can end it.
Rebecca. Or,
If other people are
Is it?
just
Okay.
too.
here we go. Here are the results.
Yeah, there's no wrong answers. You're not going to be graded on this. What's going to happen is that it helps me decide what I need to discuss about. So please go ahead and put in your answers on these polls or sing out so we know how to focus the discussion. So let's go back to the
Can
slide.
you see the results, Barbara?
I did.
So, okay.
Yeah, I will like to see them again afterwards, but I did see them. And
Okay.
I think the big thing is I think I want to have dinner with people who like water with good wine, best served chilled. The reason I put water on this and not saline is because in the field, you don't have saline. And in a big major disaster, you're going to run out of saline. So you can use water, you can use tap water. Now, on question 1, is it okay to use ice chips? No, it is not okay. Because what ice chips do is they damage the skin more. It's too cold. And when I was in school, it was okay to make a slurry of water and ice to cool the burn. Not ice chips on the burn, but water and ice together. Also, they found that's not very good either. It is much better to use water mixed with refrigerated water, something to cool it down like you do wine, down to about 55, 54 degrees. So you could take tap water and take some water you have in your refrigerator. This is if you're at home and you have a thermal burn, mix them together, and then take some gauze or a towel or a washcloth and put it right on the burn. And keep it on with a gauze or towel washcloth for 15 to 30 minutes. That will give you pain relief and will also help relieve the degree of the burn so it won't go deeper. So that's how you cool it. Next. So in the field, you want to make sure that you remove the person's jewelry and clothing from the burn, because later on as it dries, that stuff sticks or their digits swell and they can't get it off. And then we have to remove it with more aggressive methods. So any kind of clothing that is not attached firmly to the burn, you can take off. If you try to take burned clothing away from a burned area, you will pull off the top layer of skin, which actually provides some protection against infection during transport. So please leave on any attached clothing. And then you'll use the cool gauze. And I noticed there's one of my typos. And you can use the soaked in the water, put it on the burn for approximately up to 30 minutes. So you can transport the patient to our medical tent facility and have them, and at that time they'll be reevaluated. You can also, when you get to the facility, you will be treating the burn. You'll reevaluate it again and see if it looks like a minor burn or if it looks deeper than that. If it is still in the minor category, that means minor superficial, partial thickness, superficial partial thickness, but not full thickness and not deep thickness. And do you remember how we tell the difference of that? It's by blanching around the wound. If it doesn't blanch, it's too deep for us to treat. And we need to send it off for somewhere else for medical treatment if we can. If we can't, we're going to have to take care of it. But that'll be up to people manning the medical tent. And they, if we have EMTs, doctors, nurses who will take care of that for you. However, we do want to have our volunteers to be able to take care of minor because we'll run out of medical people real fast. So we'll dress the wound with a layer of non-adherent gauze. And I always used Furacin when I was in training. I did a lot of burns. I did a lot of plastics, a lot of burns, especially on kids and things. And it doesn't hurt to apply it. It goes on very easy. Just be sure to use as much as you need. And when you run out, you run out. If you've run out of it and you don't have any, you can take the antibiotic ointment and you can put that on the gauze or on the burn directly, depending on how it hurts. And then cover it with the gauze, either covered in the antibiotic or covered with the non-adherent gauze. In small burns like minor, just redness, you could also use that Telfa, that's non-absorbent gauze, and use that right next to the burn. Something that doesn't stick to the burn because that will delay healing. And that can be removed because you are going to, in the field, have to change that dressing every day. And that is superficial red, you won't have to, but the rest of them you will. And why do you do that? Because in a few days, you're going to worry about an infection. That's why. Next. So any questions on burns before we go on?
I have a quick one. I've heard that both, I know we're like really running out of time, but quick question.
Mm-hmm.
I've heard opinions on what to do with burns in terms of putting like oil or Vaseline or Neosporin on it directly, or you shouldn't because it cooks the burn. And then some people say you should do it because it seals it. What is the opinion on that?
Excellent, Jeannie, because I had a slide on that, but I took it out because of the lack of time. But it's something that will be carried on in the probably advanced first aid course too. Neosporin is not to be used on any kind of open wound because Neosporin is a sensitizer. It has neomycin in it. A lot of people are sensitive to that. So use the bacitracin. If you're going to use an antibiotic, use bacitracin. You can also even use aloe, like aloe vera from the yard. You can use that nice oil. And there have been some studies that show honey actually helps improve healing of the skin too. So those are things we'll have around the house or in our yard that we could use if we're, in the backyard for 7 days, like we've been told.
Thanks.
How long does it take? Let's see, figuring out, press a nail down, see how long it takes to go from white to red, 1 to 2 seconds. Put your question, oh, good. So ready for bones? Let's go to fractures. Okay, quiz number 4. Let's describe this fracture. Put it in chat. Can you tell me at least how you would describe this to the medical unit when you're saying, I'm bringing in this patient. I found this patient, he has a broken, what does he have? No wrong answers. It just tells me where I start on my discussion. Displaced ulna, elbow. Oh, okay. So what bone is it? Well, this picture, this is a fake because this picture only has one bone in the arm, and you and I know there aren't. There isn't only just one bone in the arm, in the lower arm. So the first thing you want to do is you don't want to call it just, I have a fractured arm, because an arm is composed of many components, and some fractures are more serious than others. And we need to know that so we can prepare for it back in the medical unit. So is it a forearm fracture from here to here? Is it an elbow fracture? Or is it an upper arm fracture? Is it a shoulder fracture? These are, and then if you want to get more serious, is it the ulna or the radius? Sometimes you can't tell. You know, if something's sticking out and it's a big one, it's probably the radius. If it's a smaller one, it's the ulna. And then is it displaced or non-displaced? That's something that you can't tell either, but you can tell if it's deformed or not. So you want to talk about the deformity. And if you look at this one, when we talk about medial or lateral, what does that mean? Well, let's go over a little bit of anatomy. The front side of you is called your front or ventral part because that's what little people crawl on, their stomach goes down. And the back side is called the dorsal. So is it dorsal or is it ventral? Is it dorsal? That's the top side of your hand, or we've named this surface differently, volar. Volar fractures are, this area is important. We call this little area of the palm from here to here, no man's land. The elbow is another area that is a serious injury. Elbow injuries give you a lot of disability if you don't take care of it carefully. So that's why we want to know about the history, and we want to know about the history of the injury. Is it a crush fracture? Is it, you know, did something fall on it? This one looks like some big jagged thing fell down and broke it clean across. So that's why we want to hear the history to see, and so we can write that down, because maybe by the time the person, if we're going to triage him out to someone, he might be in more serious condition and not be able to tell you that history. Next. We want to examine the skin around the wide area, because one of the questions we asked, was it a compound fracture or not? The definition of compound isn't that the bone is just sticking out of the skin. The definition is that there is a break in the skin barrier near or around the fracture site. And the reason you worry about that is for infection. Now, like motor vehicle accidents, you know, they come in, usually there are compound fractures, and you're in the OR for 3.5 hours irrigating and setting that wound. I mean, that's what we used to do every night, every Friday night from 7 to 10:30. So examine the area. And one of the things I picked up from reading up on this and making sure I was current was even a puncture wound counts as a compound fracture. So look carefully, look for abrasions of the skin. Maybe they fell on concrete, and the whole area that you don't see is abraded. That's another way that you can get infection into that wound, and it has to be taken care of differently. They have to be started on antibiotics because you don't want them to get an infection in the bone. So you look carefully for that before you put the splint. Next. You want to see if there's neurovascular compromise. That's a big word. What it means is that things run together in groups. You know how electricians cable all their little wires together? Well, so does your body. And it has arteries and veins and nerves, and that is called the neurovascular bundle. They usually travel together. They usually travel on one side or the other. And so that's why we have to know anatomy. So you want to make sure the neurovascular bundle works and he has a good vascular supply. So how do you determine that? Well, you want to check and see if they have a pulse distal to where they had their fracture. So if they broke their lower leg, you have to check the foot. If they broke their arm, you have to check the radial pulse. And the radial pulse is on what side of the wrist? It's on the side with the thumb. Just remember that, and you won't have to worry about medial lateral. Just remember, radial thumb. Next, you want to evaluate for motor and sensory function distal to the injury. So this is an arm. You have your hand. You say, can you move your fingers? Move your fingers. Yeah, I can move my fingers. Great. Squeeze my fingers. Yeah, I can squeeze your fingers. And then you want to see how good their grasp is. And you can measure it from 1 to 4 if you want to, but you can tell, normal. Next. You do not want to yourself, oh, can you move your arm? Let me see. Yeah, and you pick it up. No, please don't do that. Because as you move it, you might displace that fracture more. You might make a non-displaced fracture into a displaced one, and you might compromise this neurovascular bundle and turn it into an emergency instead of just an emergent situation. Next. You want to look at distal skin color. When they come up, if this arm is blue, that's got to go real fast. That means that the blood supply has been compromised. If the arm is cold, it's not getting blood either, or it's not getting blood back to the heart to get warmed up. So that's the other thing you want to check. So we call this, I call it CMS, color motor sensitivity. They also call it PMR, peripheral. Now, so this is all you need to know about fractures. Fractures need splinting because you want to prevent further injury, and it provides some pain relief. And you're not going to have pain meds. You're not going to hand everybody a Vicodin in the field. And we're not going to hand it in the hospital anymore either. So put ice on the splint. Don't put ice directly on the skin because it damages the skin, remember? So when in doubt, if you see an ankle, ankles, we have criteria that we use to determine on what is it going to be a fracture, or is it going to be a strain? The most common one, a sprain or strain. The most common one is the Ottawa criteria, which, do you want to learn something else? No, you need to learn all the bones first. Then we can go over some other things so I can tell you. But what you want to do if you think it could be a fracture, because it's just, they're not moving it well, it just looks really swollen and painful, just splint it. What are you going to splint it with? Whatever's around. What do you have in your first aid kit? Do you have a towel? Splint it in the towel and wrap it up. Do you have a comic book? I used to splint babies with comic books. It just fit their arms. Do you have, newspapers? Do you have cardboard? Anything that is around. The other thing is when you splint it as it lies. If you've checked it and it's the neurovascular compromise is not there, you can feel a pulse, the color is good, they can move their fingers. You do not move that arm around. You just splint it just the way it is. Even though it doesn't look anatomically correct, it'll be safer for the patient if you transport them that way. And then please learn about some of the bones involved. If you look at our picture diagram, this is a pelvis, and there's the pelvic fracture. That's a very difficult one to diagnose. You have to be highly suspicious for it, and we'll talk more about when we talk about it about bleeding, because it bleeds into an area called the retroperitoneal space, which means behind there, and they can die from shock and not even know it. What do you think what do you think this bone is? The next bone. Thanks, Rebecca. Any guesses? Shout it out. Jeannie, you're not muted. What do you think?
Which one are you pointing at? I don't see
The middle bone up on top.
Femur?
Oh, that looks like the thigh.
Yeah, exactly.
Yeah.
That's the femur, right? And here's the greater trochanter up at the top. See that little knob? And the little thing that sticks out to the to your right, that one, that's what joins in the joint and attaches to the acetabulum on the pelvis, which is right. If you go back to the pelvis, is this little, this little crescent thing. No, up here, more up. There you go. You're right there. Okay, and then this, of course, is a skull fracture, the next one. And now we're looking at arms, and you can see different kinds of fractures. That's another femur. here, yeah, why don't you do the arrow and I'll describe what you just do. Yeah, that is a mid fracture. That's going to need an IM rod probably to heal because it's displaced. There's no bone to bone contact, and it's in the mid of the femur, so that needs transport. Plus, it can lose a lot of blood. The next one, where's your arrow now? That one. Yeah, now that's a fracture of, she's got her arrow right next to the radius. And the bone next to that, the small one, is the ulna. Notice the radius goes right up to the radial pulse and the thumb. So that's how you remember that. And if you go farther down, you'll see a little finger fracture. And we call fingers phalanges. And then we describe them based on what part. There's 3 parts, 3 bones in there. And then that one also has to be triaged to the hospital because they broke both forearm bones, and that's going to need plating. And then here, this is the next one. That's an ulnar fracture, see, because it's on the side of the baby finger. And that one we can treat in the field. Then we go down to the legs. This is, whoa, that's a really bad one. That one's going to need plating and everything. The tibia is the arrow is next to the fibula, which goes on the lateral side of the leg. And then the big bone is the tibia, and the same thing as the forearm. You see it broke both bones in that extremity. It's going to need to be treated somewhere else besides our field hospital. And then you can see some fractures of the feet, rib fractures. Notice the rib fractures there. Some crush injury, something fell on them. And then here's a fracture of the leg, mid-femur again. So that's going to have to be triaged and treated somewhere else. So you see, when you call it in, you say, I found a patient who has good neurovascular supply. However, their left femur has a mid-shaft fracture and is very swollen. I'm concerned about blood loss over. And they say, oh, bring him on in. And then they have the person who's going to take care of the patient has some information on what to deal with. And so that's why you want to be able to describe it, so you can help in an emergency. Next. Compound fractures, we talked about that. There's 3 types. As you can see, just the puncture wound, the laceration, and then the extensive, which crush injury, muscles, and then comminuted means there's a bunch of little small bones. And then you can have periosteal stripping. The periosteum is the lining of the bone that is the growth part of the bone. It's really painful because that's where all the nerves are. Okay, next. So fracture red flags. This is what I want you to take home. Always evaluate that neurovascular bundle for neurovascular compromise, because that is an emergency and we need to act quickly. The general rule is splint it where it lies, but you've checked the neurovascular bundle, it's not working. You've got to try to reposition it anatomically, how your arm looks or how your leg looks, and see if the supply gets better. And still, you got to transport quickly. The cited increased risks for acute compartment syndromes. This is something we're going to talk about probably in advanced basic first aid, because there are certain areas where there's a lot of muscles, and if they have fascia lining them, so that if they get a lot of swelling or blood in them, they will cut off the blood supply, and you also have morbidity with that. Pelvic fractures, you can get hemorrhage with and be unrecognized and go into shock. And then the compound fractures, we worry about sepsis afterwards. So now bleeding. Oh, I spelled bleeding wrong. That's really terrible. Next.
I think we're almost at time, Barbara. What should we do here?
Okay, bleeding. The main thing about bleeding is direct pressure, direct pressure, direct pressure, and elevate the extremity if you can. You need to put the direct pressure on for at least 5 minutes. Next slide. In uncontrolled bleeding, if they have mental status, they get confused or agitated. Immediate care, if the extremity is still oozing out or you have an amputation, you can put on a tourniquet, but you need to know how to apply it. It can stay on for up to 45 minutes. And then ongoing care, you got to transport them. Next. Blood loss, the average person has over 5 quarts of blood. If you have a 40% loss, your heart rate goes over 100. your blood pressure is a little low, respirations can still be normal. However, in kids, usually respirations go up first. Your heart rate can be low because you're on beta blockers or something for your high blood pressure. So we can't always rely on that. And then over 40% is critical, and over 50% you die. Next. That's the criteria for rapid transfusion. So then we talk about traumatic hemorrhagic shock. Loss of circulating blood volume is the most common cause of shock. And you can read the other factors. It's treatable if you diagnose it. So you've got to have suspicion that this person is in shock or going into shock. Next. So class 2 is moderate, where you've lost to 30%. Class 4 is severe. And I put in red below presentation level. That means what you got in the field, the blood pressure that you got in the field, the first blood pressure you have on the chart. If it's below that level, if it goes down 20%, we've got to get moving, do something else. Next. So you got to recognize the warning signs: the cold, clammy hands and feet, the pale or blue tinged skin, weak pulse, low blood pressure, the altered mental status. If they just don't seem right, they're agitated, they're anxious, they're concerned, they're not following simple commands, let alone two-step commands. Next. So initial management, you got to recognize it. That's what you have to do. You got to get your baselines. Stop the blood loss. Keep the patient warm because they've lost blood. They're not going to, they're going to be cold. Elevate the legs. You don't want the blood pulling in the legs. That's going to be hard when you have a fractured leg too, because you got to worry about the neurovascular bundle of the leg at the same time. And you got to identify the major threats like pneumothorax, cardiac tamponade, et cetera, which you don't have to. You got to transport it to us so we can identify it. So you've got
Barbara,
to
let's do 2 more minutes. Barbara.
Yep.
Okay, cool.
This is what we do. Our ongoing care, which the only thing we can do is keep the vitals. Next. So head injury, next. This is a head injury. Indications: they've lost consciousness, nasal discharge, they have a stiff neck, they have a scalp wound, they have a fracture of a bone in their face, they have bruising or swelling. Next. However, we don't talk about head injury very much anymore. What we talk about is traumatic brain injury, TBA. And this is an alteration of the brain function. I mean, a fractured skull, I don't care, it'll heal. But the brain is another matter. So it's caused by an external force and trauma. Next. I want you guys to know the new terminology. So these are the type of the external forces. All of these can occur in a major disaster. This is usually MVAs or football, acceleration, deceleration of the brain. Next. So now let's talk the scalp wound, bleeding. Gotta worry about bleeding. You can put clamps on that to stop the bleeding. Fracture, eye movement, you gotta see about that. Swelling and bruising, of course, because you lose the landmarks. Loss of consciousness, how long? Nasal discharge, if they have a clear nasal discharge, it means that they might have what's called an ethmoid fracture of the ethmoid sinus, which is right up over the nose, going right into the brain. Next. So closed head injury is what we're usually going to see. And it happens when you hit your head on a hard surface. It can result in all of those things we talked about. And a mild one is called a concussion. Next. So there's the signs of it. You can have just tons of signs: nausea, headache, swelling, dizziness, you feel tired and sleepy, all these kinds of things. But the symptoms depend on the severity of the injury. So loss of consciousness, if they don't wake up, if they wake up slowly, that's a much more serious. If they're awake and alert and then they become unconscious, that's another serious one. Next. So skull fractures, the epidural hematoma, that's the one that's outside the brain. The history is that they hit their head, usually around the temple area, and half an hour later, they're unconscious. This is a medical emergency that needs to be evacuated or they'll die. Next, subdurals, you can have those. As we get older, our brain atrophies, so we have a lot of room for subdurals. Lots of people who fall a lot walk around with chronic subdurals. Acute is a little different matter because you don't get, your body doesn't adjust acutely. Subarachnoid hemorrhage, that's a blood vessel. Interparenchymal, that's like a stroke where you damage the inside of the brain. The contusion, we talked about that. That's a bruise on the brain. And then the ventricles of the brain can get blood in them, and that can cause pressure and you can die. Most common thing is you will have a dilated pupil, probably on one side. Next. Hypovolemic shock, sepsis, and electrolyte imbalance are secondary causes of TBI. They gotta go to the hospital. That's it. Any questions?
Yeah, please chime in or type in the chat. Barbara, that was amazing. So many action items.
Well, I just wanted you to have
really
something
great.
new,
So helpful.
not just the same.
Does anyone have
same.
any? I appreciate that. Any questions in the chat? We end at 10:15. I will let the meeting go on, but I'll officially end once to make sure we don't have any questions.
Remember, there's
here.
no wrong question.
We're getting no wrong questions, but there's also no wrong compliments, and you're getting a lot of compliments because that was a great presentation.
A little fast.
Lots of praise.
Yeah, that was amazing, Dr. Kostick. Thank you. And for those who have been taking notes as quickly as I have, we will have these slides available on the website. So
Yeah, but let me spell check them a little. Rebecca, will you spell check them and fix them, please?
we'll
That's
have them
scary.
available. They'll be checked or whatever we want to do between now and then. And we'll also have a summary handout so that you can print it out, keep it in your binder if you're an area coordinator, keep it on your fridge if you want to be extra ready. I did have a question about the gauzes you were talking about.
Mhm.
You had mentioned a bunch of different types. Is there one that you, if I'm going to buy one type of gauze for my kit or maybe two, what
Mhm.
would you recommend I start with?
Well, when you mean the non-adherent gauze, or do you mean the?
Right. When you were
Yeah, the
talking about,
non-adherent, I'd put some Telfa in, the TELFA. That's the one with a little, just because it doesn't expire. And then if you have a lot of burns in the house, I'd take that A.D.A.P.T. But I prefer Furacin, but you can always put that on later. You know, it's right away in the field. You want something that's going to last and work. And then when they have to be moved to a trauma burn center, they'll rebandage everything and relook at it too. Because remember, the burn, the way you classify the burn changes over time. It can change up to 1 to 2 weeks after you have a burn to show up how extensive the damage is. And then you also, for bandages, you want some 4x4s, you know, just gauze, plain sterile 4x4s. You want the unit ones so that they stay sterile, and that way you don't have to throw them out. And then you also want a thing of Curlex, because that's what you wrap the burn in, and you can also use a Curlex to help wrap a splint.
great. Thank
And
you.
then Tom has talked about first aid kits, and Dr. Paul also put a list up on the website about his first aid kits.
And Barbara, maybe in an email afterwards, or we can make sure we get the spelling of all those things, and we can put it in a follow-up email. Robin, I see your comment. We'll make sure we get the product names and everything spelled out and
Sure.
ready for you guys.